So the next talk is a joint presentation between Katherine Walesby and Graciela Muniz-Terrara. Katherine is also a geriatrician who has moved to Edinburgh to work. Graciela is really a senior lecturer in biostatistics and epidemiology, working at the Centre for Dementia Prevention in Edinburgh. Our two speakers had an involvement in EPAD, which was probably the most extensive project to try and acquire data in people who were cognitively normal, who might progress on to develop dementia. Unfortunately, the second phase of that, which would have involved the type of trial that Savanka so eloquently described, being done, an adaptive multi-arm design, but unfortunately that didn't go ahead, and we still await alternatives from other potential sources. So Katherine and Graciela are going to talk about rural and urban differences in dementia, and I will hand over to them.
Thank you very much. I'm going to talk first, and then Graciela is going to follow, developing some more discussion points, and hopefully we'll have lots of questions from you as well. Can everyone hear me okay? Hopefully, no answer is good. I'm going to try and share my slides now. I'll just check. Can everyone see those slides okay?
Yes, we can.
Thank you. So my name is Katherine Walesby. I'm a clinical research fellow in geriatric medicine and a specialist registrar, and I'm at Alzheimer's Scotland Dementia Research Centre. I'm undertaking my PhD on geographical variation of dementia, and that's involved looking at this within big data sets in both Scotland and New Zealand, and another large chunk of it is a systematic review looking at rural and urban dementia differences and the variation. So that's the part that we're going to focus on today, and I'm going to give some preliminary findings from the systematic review, and Graciela is going to follow with having some discussion around why there may be differences between rural and urban dementia rates. So the background, as you all know, worldwide dementia prevalence is expected to rise to around 78 million in 2030. The greatest increase is expected in developing countries, and there's been a lot of work previously highlighting that there could be geographical variation of dementia. In particular, I'm showing Tom Russ's work from before, looking at a Scottish cohort, and as you can see in the maps, the odds ratio is higher in the north than the south of the country in terms of dementia, and this has been shown also in other countries, including in Sweden in the Swedish twin study. Another important factor in all of this is obviously the recent Lancet report 2020 that added 3 more risk factors for dementia, one of them being air pollution. And obviously that's important in terms of environmental risk factors that might influence differences depending on where you live. Some of the work that I've published, and there's a poster up today on that, is looking at the differences in New Zealand in the geographical variation of dementia. I'm going to briefly show you this in the slide and focus the rest of the presentation on the systematic review, but if you're interested, the QR code there should work for the full paper published. We used big data and ascertained who had dementia and where they lived, and we showed that there was higher dementia rates in the north and the south of the island over a series of 4-year period. So the results were interesting as they were slightly lower than national current estimates, which are not based on New Zealand's data and are extrapolated from other countries. As I've demonstrated, it was higher in the north and the south, and we'll discuss some of the differences in general about geographical variation of dementia, and particularly rural versus urban. And they were different in different ethnicities as well. So the focus of this presentation is the systematic review, which you can find registered via Prospero here. So a previous systematic review done in 2010 highlighted increased dementia in rural areas. Now, this was very interesting. It also highlighted that there was a lot of heterogeneity in the methodology, so it was hard to conclusively tease out the true differences, but that the odds ratios were higher in rural area than urban. Since then, there's been an explosion of papers investigating geographical variation of dementia. And that's partly because there's also a growing interest in health-related outcomes related to the environment in general. So you'll be aware there's many other chronic conditions where people are interested in where you live and your risk factor for developing them. So when we repeated this systematic review, we found that there was such an explosion of papers that rather than doing a whole geographical variation of dementia, including country-to-country comparisons and different levels of geographical comparison, we had to focus it down to rural versus urban dementia just due to the sheer volume of studies. So I think that kind of represents it's an interesting area that's expanding. So these are preliminary results. We hope to submit in the coming weeks, months, so I would be grateful if you don't tweet these preliminary results. We started our systematic review doing a large database search, and as you can see, there was a large number of records identified, new records since 2010 of over 20,000 studies. We managed to deduplicate them and screen them down slightly to around over 13,000 that we had to screen the titles and abstracts. And after excluding a few more, we managed to get it down to 530 full text to review. This was still quite a substantial systematic review. When we excluded reports at that level, there was a number of reasons, as you can see on the right-hand side, including that they weren't looking at the patient population we were looking for, or that they weren't comparing two geographical areas, or there was no spatial variable as well. This left us in the included studies at the bottom with actually on the left you can see 154 studies included, which is why we had to narrow down to actually look at rural versus urban. So we had 38 in the final analysis looking at rural versus urban, and 27 of them in the meta-analysis, which was actually more than we had anticipated for the meta-analysis. So this, as you'll be aware, is a forest plot of our results and the studies that were included in the meta-analysis. They're listed in terms of alphabetical order of the studies, and the years you can see, and the countries in terms of, there were a few countries that had produced several studies looking at geographical variation, China being one of them, USA being another one, but we did have a spread across countries that were both considered resource-rich countries and resource-poor countries. The size in the next column you can see varies substantially, and there were some very, very large studies, and those studies were done undertaken using electronic health data, so big data, and were all done in resource-rich countries. Moving to the next column, you can see the rural on the left of the midline and urban on the right. And what this means is that the studies that were moving to the left in the rural area showed that there were higher odds ratio of rural risk of dementia. And the studies on the right of the midline showed that the odds ratio for dementia were higher in the urban areas. Now, many of the studies had very wide confidence intervals, and overall, there wasn't really any conclusive result that we could take from this. Most of them, as you can see, are centered around the midline. Nextly, we obviously did a risk of bias, and most of you will be familiar with this within a systematic review. We scored the studies based on whether there was any bias in who they selected as participants, the confounding variables that might affect the outcome results, the measurement of exposure, and for us that was geographical variation, so rural versus urban, and how they defined their geographical area and how they defined rural versus urban. And then also we looked at risk of bias in terms of the incomplete data, what they did with missing data, and how they selective outcome reporting as well. I think the key finding from this is that the measurement of exposure, which is obviously really the key thing we're looking at in terms of rural versus urban, had over 50% in the high risk of bias, and a lot further in the some concerns or unclear. And what this means is that we weren't convinced that there wasn't risk of bias in how they defined rural and urban, and that was apparent because a lot of the methodologies didn't actually describe how they defined rural and urban. Some did, and this varied between different countries, and we'll chat a bit more about this in the discussion, but it is quite important to kind of consider that aspect of risk of bias in our results. So we did some other sensitivity analysis by removing the high risk of bias studies, particularly the ones for the measurement of exposure that didn't really describe rural and urban areas and how they defined it clearly, and that didn't actually make any difference in the overall forest plot when we plotted it again, or the overall odds. And we also removed resource rich and separated resource rich countries to see if there was any difference there, and we separated the countries and studies that used electronic health data, so those massive population samples, just to see that we weren't seeing any bias when we were doing our meta-analysis. And changing all those factors didn't actually alter the overall results from that forest plot that I showed you earlier. So I think the key findings from the systematic review are that obviously geographical location is important. We're having growing interest in where you live and your risk of health and where you might access services or not be able to access services. But when we're looking at it in a systematic review, what do we really mean by this? Because there are rural and urban differences in different countries, and trying to combine them when there's different variation in the methodology, and in particularly how they may or may not define rural and urban, is quite important to consider when we're analysing what we might be thinking as, oh, this area may have a higher risk of dementia versus another area. The ascertainment of dementia was varied, and there was different methodologies across all the papers. Obviously, the cohorts that used electronic health data and big data used ICD-10 codes, and we don't know what went into the defining that person getting the ICD code. So what methods were used to ascertain dementia, and what cognitive tests were used for them to then have an ICD-10 codes. And that's the limitation with all big data. And then the more traditional epidemiological studies, face-to-face, they had smaller sample sizes. They often used several phases of assessment, a screening survey followed by a battery of cognitive tests, and some of them also imaging as well to define dementia. There were predominantly larger studies from resource-rich countries, although we removed the electronic health data ones, which were massive, large studies, and it didn't alter the results. But it is something to consider moving forwards when you're looking at geographical variation at an international level. and the explosion in interest in big data that is largely in resource-rich countries. Lastly, the two last points are very closely linked, but there is a life course approach, obviously, to your risk of dementia, age being the biggest risk for dementia, and this increasing significantly from when you're 40, 50, to 60 to 80. But across the whole life course, there are critical periods, as we say in epidemiology, that may or may not produce risk factors for dementia, or indeed you may have a protective factor for dementia. And what we know is, looking at geographical variation of dementia, and particularly rural versus urban, late in life is not always very effective, particularly if you look at mortality data. So where you die is not necessarily going to be meaningful, because that might actually just report where someone is in terms of a care home, rather than their actual risk of living in a rural or urban environment. And so trying to establish actually what is the true risk of living in a rural and urban area needs to factor in that life course approach, but many of the studies obviously don't, because of the nature of dementia being something that you get later in life. There were only a few studies that looked at dementia at different points in time, and only one that actually looked at childhood versus adulthood residents in terms of your rural and urban risk, and compared this with your risk of dementia. And that's probably something that going forwards, more studies need to look at different points in time to actually get a meaningful conclusion of rural, the risks of rural versus urban living and dementia. So before I hand over on to Graciela, who's going to talk a bit more about why could there be differences between rural and urban dementia rates, just like to thank obviously the funding bodies, my supervisors, co-authors, and the team in New Zealand that I worked with. Thank you very much.
So thanks, Katherine, and thanks, Tom, for the invitation to present. It's fantastic to be here today. And I wish I could be there in person, but I'm self-isolating because I just came back from the US, so I'm waiting for my COVID test results. So that's the reason why I'm not there in person. So Katherine presented the results of this systematic review, which she has been working on, and I think that the results are very informative, and particularly my reading of the findings is that there's a lot to be done, that needs to be done, to really understand the differences in rural and urban aging populations, and particularly in relation to dementia. And one of the aspects that was really striking is how heterogeneous the definition of a rural environment, a rural setting is across countries and within countries. So that is a serious limitation. Well, I'm not sure. I used to say limitation, but perhaps it's not a limitation. But that is a factor that is potentially undermining the strength of the conclusions that we could come up with. Another aspect that the systematic review highlighted, and Katherine's presentation also was very clear about that, is that we don't really know about the prevalence of risk factors across in rural areas, and particularly if we start thinking of the life course, that is a key issue. So if we think of the, say, Lancet Commission report and the risk factors highlighted in the Lancet Commission report, it would be really interesting to try to see the differences in prevalence of these risk factors, again, within and across rural and urban settings, with some sort of definition of rural and urban setting that within the studies we could look into. And particularly, this is really important to look at population representative studies, because some of the studies are not really population representative. So that would be another factor that needs to be taken into account. Another aspect that I thought that was really interesting is that when we think of the rural and urban settings, and the wider health disparities are seriously confounded. I'm just bringing up an example of a study I am working. A data set I am affiliated to is a study of in Bangalore in India, and it's a rural study. And if we think, well, it's true, it is rural, but the population involved in that study is over 90% is illiterate, and there's like, for example, men are slightly more educated than women. So is it the rural, or is it the general socio-demographic setting of these populations that are driving the factors that we are seeing in terms of aging and dementia in these groups? So those are aspects that I think that really need to be addressed and fully understood a bit more, or understood a bit more. And another aspect that Katherine was highlighting is the differences in access to resources and to healthcare and diagnosis. So, as I just mentioned, I was in the US until 2 days ago, and it was really interesting because I was working in a rural study in Ohio, Kentucky, and Tennessee, and Arkansas. And what we were discussing with the local investigators was the lack of opportunities that the individuals living in rural areas in these states have in terms of socializing, engaging in cognitively engaging activities and things like that. So of a healthier lifestyle is harder for populations in those settings. So it's the access to these resources, to opportunities in rural settings is more limited to the access of this opportunity and healthier lifestyles that urban populations may have. So that's another factor that needs to be considered. And of course, healthcare and diagnosis is another aspect that I think that somehow we are fortunate in the UK to have access to healthcare and diagnosis, but still, I think we could work a bit more in that regard in terms of understanding the impact of being in a rural setting. Katherine also mentioned that most of the work, most of the evidence that we have comes from rich contexts, rich countries. And I think that is absolutely true, and it's coming out in her review. But also, currently, there's if you want, there's a push, or there's a sort of energy in the system, in the research system, in terms of research in dementia in low and middle income countries. And even though in the context of low and middle income countries, we use that term as a big umbrella, the differences in rural and urban populations in those countries is also really shocking. And for example, in America, there's the issue of the population, right? So all these rural settings, rural areas are becoming depopulated, right? But also there are geographical variations. For instance, in the southern part of the US, that's one of the bigger sources of information about this topic. In the southern part of the US, you have a lot of migrant population, so Latino, farmer, workers working in farms, for instance. Whereas in the middle part of the country, we don't see this ethnic variation, but so we have a predominantly white population, but it's also, the younger generations are leaving the place. So those are aspects that may be happening more in some countries than in others. So again, even though we are trying to get more information, the variety, the variations in the studies, in the populations and the context is really quite important here. Definitely, I am 100% certain that we need more research with this focus and on rural and urban differences. But there's another aspect that is that has been discussed quite a bit in the literature in this area, is that it would not be adequate to talk about a unique rural aging profile, if you want. That there are too many differences and too many factors that affect this idea of rural aging, and therefore, like, putting all these factors and trying to figure it out as a unique single process might not be the best way forward. So there's some research coming out of, again, from the US, looking at the southern part of the country and the northern part of the country and saying, well, fine, these are both rural settings, but need to understand, because the factors there are different. So I think that particularly if we bring it back to the UK, I think we have fantastic opportunities. And say in Scotland, it's a country geographically relatively easier to understand, and with opportunities such as Generation Scotland and others, I think there's great opportunities to do research on rural aging in Scotland. So with that, I'd like to finish and happy to answer any questions. Thank you.
Okay, so thanks again to both of you for a very comprehensive presentation on a most interesting topic about where factors perhaps unthought of in the past might influence how dementia is developing in an ever-increasing population that we have.
We are not having any questions,
Well, I'm just maybe. But anyone from the floor with any questions? Oh, there is one on the chat that I see, which is about, and this is probably for Katherine, how about looking at data where the patient was living at the point of dementia diagnosis? Would this influence the outcome of the review?
Yeah, no, I think this is really important, and obviously the ideal study would be to do that. From some of the studies where they've gone, the face-to-face to ascertain who's got dementia, done a screening assessment, and then focused on the ones that didn't already have dementia diagnosed. I suppose there's difficulties in knowing when they really got dementia. You're giving a diagnosis based on a study that you're going there to recruit and find people, but actually that doesn't necessarily mean they haven't had dementia for a while, they've just not had it diagnosed. So I think definitely your ideal study would be to have a life course approach, know exactly when they get diagnosed with dementia, have several points in time where you can factor in where they were at points in their life geographically, and then factor that all into your analysis. Unfortunately, those perfect studies don't really exist. So yeah, I mean, it would be great to have a lot of studies that knew that actually that was the point in time dementia was diagnosed, but that can be hard to actually capture in real time.
Okay, thanks. And a second question is about sort of subgrouping the results. So if you were to group all the studies where rural was greater than urban, and group those where urban was greater than rural, would there be systematic factors or patterns that could explain the observed heterogeneity?
That's a very good question. and one we probably need to look a little bit more into for the final results that we're going to put into to be published. But there is still a lot of variation in terms of some of them would capture cardiovascular risk factors and some of them wouldn't. The very interesting study that's done in America, the Indianapolis group, looking at African Americans, and that was the one that looked at childhood residents and adulthood residents, and they found that years of education played a factor in decreased risk of dementia for those that were living in a rural environment in childhood, but didn't have the same impact if you were living in an urban environment in childhood. So I think definitely looking at the factors, the variables that influence the differences are important, but there's also that life course effect that is actually really, really important to try and capture, and a lot of the studies don't look at that. I mean, that has many variables there that can perhaps be influencing it, not just education, but obviously ethnicity, and also that cohort had a big movement from south of America up to the north during their lifetime. So yeah, there's much more to be done in terms of trying to understand more of the variables involved, as Graciela said, in terms of the variation between rural and urban studies. Unfortunately, some of the studies are so heterogeneous in what they collect and their methodology that it's hard to kind of clearly differentiate that in the meta-analysis.
And adding to that, I see that this question comes also from Mario, who is very familiar with the low and middle income countries context. And do you know how hard it is? So if it is hard to do research in rural settings, in high income context, I'm pretty sure that it can be appreciated how difficult it is to do
absolutely
research in low and middle income countries. So again, I think it is in terms of opportunities rather than limitations.
Okay, and the final question before lunch is, what about rural versus urban differences in different types of dementia? Arguing perhaps vascular dementia might be more prevalent in urban settings.
Yeah, definitely. This is a really important question. And one you'd think it would be higher in urban settings. Unfortunately, only a few of the studies actually differentiated, also capturing that those results for rural and urban to create odds ratios for the different subsets of dementia. And I think there's a long way to go with that, because even in the big data that I analysed in New Zealand, and that's electronically captured health data, the different subtypes is even less well recorded than overall dementia. And so a lot of the studies that you find in the systematic review are just talking about dementia in a broad umbrella term. Some of them do specify specifically Alzheimer's dementia, particularly when it's in electronic health records and it's easier to extract those ICD-10 codes. And a lot of them, there was only a couple that actually did vascular dementia, and nothing really that meaningful that we could actually do any meta-analysis on, unfortunately. Yeah, it would be really important to try and understand that more. But to get to that stage, we have to go back to having better coding, having the right diagnosis put in to electronic health data for those studies, as well as having face-to-face epidemiological studies that are able to kind of work out whether it's vascular versus Alzheimer's, and a lot of them are looking at it in a broad term. But I think that is really important in moving forwards.
Okay, so thanks very much, Katherine and Graciela. So we can bring the morning session to a close now. and it's lunchtime. So if I ask you to just do the same as the coffee and pick up your lunch and then come in and feel free to circulate around in the larger room here, but try not all congregate in the small area where lunch is being served. Is that right, Emma? It's just, yeah. Okay, and then we should see you back at 1 o'clock and we'll start the afternoon session then.